All right, party people, we are back at it with another one. Let's get it. So we have a 40-something female with HIV suffering from fatigue and chills. She's currently in the hospital for infective endocarditis. She's been there for a month. She's been receiving long-term antibiotics. The patient is started on micafungin, and I am asking you where the site of action of this drug is. Now, the way to approach this is to understand that for most uncomplicated fungal infections, they are treated with azoles, broadly speaking. If the infection seems mild or localized, we should think about fluconazole first line. However, high fever and chills like this patient is experiencing, with rigors, this may point towards disseminated fungal infections or fungemia, that's fungus in the blood, or even a CNS fungal infection. So for serious systemic fungal infections, the go-to treatment is classically amphotericin B. Again, for uncomplicated, we're thinking azoles like fluconazole, and disseminated or CNS infections, we're thinking amphotericin B. However, in this case, she's febrile and sick with fever and chills, so we suspect fungemia. She's been in the hospital for about a month on IV antibiotics for endocarditis. That's highly suggestive of fungal infection because broad-spectrum antibiotics wipe out normal flora. This increases the risk of fungal overgrowth, classically candida. Now, you might miss this and say, why is it a fungal infection? Now, the answer is she's been prolonged antibiotics for 4 to 6 weeks. It's easy to overlook, but it's high yield. So remember, prolonged antibiotics increases your fungal risk. Now, in terms of fuzzy descriptions for candida, you have to know that if they give you elliptical purple budding organisms, this is candida. Just like for other buzzwords that you need to know is tumbling motility, this is listeria, swarming motility, this is salmonella, and in the case, again, if they say elliptical purple budding yeast on blood agar, that is your candida. All right, let's run through these possible answer choices. Now, if they were to mention fungal cell wall inhibition, this refers to echinocandins, caspofungin, and micafungin. They inhibit beta-1,3 glucan synthase. This is an enzyme needed for cell wall carbohydrate synthesis. These are used for invasive candidiasis as well as aspergillosis. So yes, micafungin is the correct answer here. Now, even though amphotericin B is often used for severe fungal infections, this question is specifically testing your knowledge of micafungin. This is first line for candidemia and invasive aspergillosis. Now, another possible option choice would have been ergosterol binding. This is amphotericin B and nystatin. These drugs bind ergosterol from pores in fungal membranes. Now, amphotericin B is used for serious systemic infections, especially cryptococcal meningitis. This is given with flucytosine followed by a 1-year fluconazole taper. Side effects include hypokalemia, hypomagnesemia. This is known for its amphoterrible reactions like fever and chills. Nystatin is typically used topically or as a mouthwash for oral candidiasis, and sometimes for vaginal candidiasis. Please note for esophageal candidiasis, you use oral fluconazole, not mouthwash. Do not confuse these two. Another possible option would have been ergosterol synthesis inhibition. This is azoles. Azoles, when I mentioned those, I'm talking about fluconazole, itraconazole, voriconazole, ketoconazole. They inhibit 14-alpha demethylase. This converts lanosterol to ergosterol. Ketoconazole also inhibits CYP450 and androgen synthesis. It's anti-androgenic. Azoles are hepatotoxic. Now you have to check your LFTs before giving oral formulations. Topical azoles such as clotrimazole, miconazole are used for tinea corporis and tinea pedis. Please note, if both azoles and terbinafine are listed for tinea pedis, the answer is terbinafine. But if only miconazole is listed, then that's your answer. Itraconazole is classic for sporothrix schenki. This is Rose Gardner's disease. Voriconazole is used for invasive aspergillosis, but can cause arrhythmias. Now, as far as squalene epoxide inhibition, this is terbinafine. This inhibits the conversion of squalene to lanosterol. This is hepatotoxic, so again, you have to check those LFTs. This is used topically for tinea pedis and oral for onychomycosis. This is nail infection. Finally, microtubule inhibition. This is griseofulvin. Oral griseofulvin inhibits fungal microtubules. This induces cytochrome P450. Only used in tinea capitis and for the affected patient, not classmates. Again, your licensing exam, for whatever reason, loves this detail, so I reiterated, and it's repeated from previous questions. So let's spin the block. You can get fungal infections from prolonged antibiotics. Think candida. Micafungin targets beta-1,3 glucan synthesis. You have to know what each antifungal targets, whether it's cell wall, membrane, synthesis pathway, or microtubules. Now, these are all high yield for your licensing exams. All right, that's it for this one. If you like the video, please subscribe and like the video. Go crush it.